TopMedTalk.
Well, hello and welcome to TopMedTalk. I'm Desiree Chappell, Managing Editor of TopMedTalk and Vice President of Clinical Quality for North Star Anesthesia. And I'm joined by our Editor-in-Chief, Professor of Anesthesia and Critical Care at the University College London, Monty Mythen. Hello, Monty.
Hi, Desiree. Great to see you. Great to talk to you. It's been a few weeks.
It has been. We haven't done anything official for, well, actually, you know what? We took a little hiatus off the World Congress, didn't we?
we had the World Congress there, the evidence-based perioperative medicine and the POCA-palooza, live from London and around the world. And it was a great success, a very great success, I think. Lots of compliments about it. I must admit, I was a little bit disappointed that it was completely virtual again, but, you know, apparently our country's just opened its borders. So let's see how that goes.
I'm sure swimmingly well. It was actually funny because you had more people in London during our first virtual conference back in 2020 than you did this time because it was everybody was locked down. The Girl Scouts couldn't even come up. It was
we had a slightly bigger team in the studio, but this time we just managed to hit the surge of our Delta variant, which has kind of ripped through, thankfully, although there's been a lot of it and people have got sick again, and we've opened up our COVID intensive care unit. It does largely seem to be affected unvaccinated people. So, you know, very sad for those people who got very sick with it. We're busy, but nowhere near as busy as before. So fingers crossed, let's hope this is the beginning of the end. The end might take a while, but let's hope this is the beginning of the end.
Yeah, absolutely. Well, we had some great conversations with our friends around the world. So be sure to check those out about kind of the state of COVID. I think is always kind of good to understand the international perspective on it as well. So speaking of international, we are an international perioperative medicine podcast, aren't we, Monty?
We are. We are hoping to bring you lots of exciting stuff through this year. As always, we've actually reduced the frequency with which we put out podcasts based on feedback that we've got back from people. They felt they were drowning. What's the expression? Drinking from a fire hose. Is that the one?
I think that's good.
I think I understand what that one means now. So we've taken the heat out of that a little bit. We just spaced them out a little bit more. That seems to be very popular. We get little spikes during the week when people are more likely to listen. And hopefully we will be back on the road soon. You know, all the sort of usual things about requirements of our clinical commitments and safe travel, etc. But at the moment, we're scheduled to actually be running our EdPom Ireland conference in September 21 to 23 of this year from Ireland. Mm-hmm. And we're scheduled to be running EdPom USA from Chicago. And we're also at the moment supposed to be at Anesthesiology 2021, the annual Congress of the American Society of Anesthesiology, that we have been for a number of years now, which is in San Diego later in the year. So let's see how all of that goes. But maybe we'll be back in the room with people bringing you the latest, greatest breaking news soon.
Well, you know, we can't do any of this, Monty, without the generosity of the sponsors who make it possible, and that we can keep this free to the world. So we wanted to thank all of our sponsors, especially our platinum sponsors and Edwards Lifesciences, for the support that they've been giving us since the beginning. So thank you very, very much for that. Well, Monty, I want to jump right into our guest today. We love speaking to people from all different backgrounds in the perioperative space. Today, we have the opportunity to talk to an anesthesiologist from Missouri. We have Brad Cardonell. He is Assistant Professor of Clinical Anesthesiology at the University of Missouri School of Medicine. And he also serves as the Director of Cardiovascular Anesthesiology and the Medical Director for the University Hospital in Columbia. Brad, thank you so much for taking the time out of, I'm sure, your busy day to join us.
Thanks for having me. It's been great. It worked out perfect. I'm on call this week, so I have a little bit of time in the morning before I go in to see what's there for us.
Great to see you again, Brad.
Yeah, good to see you, Monty.
Yeah, well, we've had the opportunity to do a little work with Brad and just loved hearing, you know, the cardiac perspective and enhanced recovery. And so we thought it would be great to kind of get back into that today and have a little bit more discussion specifically on TopMedTalk about it. Brad, before we dive in, give us a little bit about your background, your history, and what you do there at the University of Missouri.
Yeah, so I've been at the University of Missouri for about 3 years now. I finished residency at Geisinger Medical Center in Pennsylvania, went on to fellowship in adult cardiothoracic anesthesia at Cleveland Clinic. And then from there, I came on to staff at University of Missouri. Got here, and the program is kind of in a rebuilding for cardiac surgery, at least. We've had almost complete turnover of our surgeons since I've been here in 3 years. And then probably about 50 to 60% of our anesthesiologists have turned over as well. I've had the opportunity to kind of look to see where we can improve things and kind of standardize things. And of course, when you do that, you look at ERS and it kind of is all written out for you just to get best practices, check the boxes, make sure the patients are getting the best care. We, at the University of Missouri, we've been lucky that we, of course, had other services lead the way. It's not typical that cardiac surgery would be the first one, and it wasn't at Missouri. So one of our, the medical director that took over, that was medical director before me, had a big focus on ERS as well. So we have protocols in hepatobiliary for our Whipples, for urology with cystectomies, colorectal. We just rolled out bariatric surgery last week. And that's kind of where I saw the opportunity in cardiac surgery is when I came, there wasn't standards for anything as far as just TXA. It wasn't even standard. Glycemic control. Those things just were attending dependent on who was overseeing the case. And so I thought the best opportunity would be to look at ERS and check the boxes from there. And the hospital administration were very excited about it as well and gave us quite a bit of support to help develop it. So it's been a good experience. It's not easy, but I think it is worthwhile. And I think the data will speak for itself in the next 6 months to a year when we're able to look at that.
That's great.
Can I comment for a second, Brad? You know, I grew up in cardiothoracic anesthesia, critical care. Desiree, I don't know if you still do Desiree, but Desiree's done plenty in the past too. And one of the things you referred to is that even within a single organization, people may not appreciate this. You think there'd be one way of doing things. Whereas according to typically the attending cardiothoracic surgeon, they used to historically have an order set that could cover the whole spectrum if you had 8 or 10 surgeons of various different versions of the truth that went from, let's take fluid, for example, crisp them out to half drown them. What's it, you know, you're new with a new team. Can you just reflect on that challenge and if you've had a chance to get through a lot of that by saying, look, we're starting afresh?
Yeah, I think that was the advantage of where we were at in our program too, is that we were able to have that rebuilding and no one was stuck in their ways as far as everyone gets 9 liters of normal saline or something like that we had to overcome. So the surgeons were amenable to the changes. They weren't necessarily as gung-ho about kind of doing the base work, but they were amenable to the changes once we got them implemented. And so it was kind of anesthesia driven for this one with our surgical partners. And then we had good leadership from nursing as well, which is very important in these ERS protocols to make sure that we have buy-in as well. I will say the unique thing about Mizzou is we are the Mizzou Tigers. So these are not ERS protocols, they're Tiger protocols. So we have Tiger protocol patients and those patients get a special placard on their outside of their door to know that they're part of the protocol and that we need to make sure that we're, again, checking the boxes for best practices.
Does it look a whole lot different between the different service lines? And then maybe if you could kind of dive in a little bit more into what does your protocol kind of look like in general?
Yeah, I think there are definitely common grounds between the service lines. I think we're trying to liberate, our fluid status from the beginning, NPO, that is no longer after midnight. We're trying to have more trust in our patients. They understand that they need to, finish the drink 2 hours prior. And if we just look at that protocol itself, I mean, we had spine surgery that just implemented. That's the only thing they implemented this year. And they saw their infection rate go down as well as their glycemic control improve as well. And that was the fellow for the year's project. And they had an Ensure drink 2 hours before, and they saw significant outcomes just from that one protocol. So I think that's one of them that's common ground. I think, perioperative glycemic control, multimodal pain control, which the anesthesiologists were heavily involved in to try to help the surgeons understand or allow us to prescribe some pre-meds as well as perform regional blocks for these patients. So we're not just relying on the opioids, both intra-op and post-op. Patient engagement has been a big thing for Mizzou as well. We haven't quite gone to the level of interfacing with apps and cell phones and stuff. I think we'll eventually get there because they've seen the benefit from our Tiger protocols, but we're at least having binders to let the patients know what to expect, and having checklists for them as well to know that, you need to see PT, OT, ensure you drink your drink 2 hours before you'll get there. You'll take some meds. Surgery, post-op day 1, we want you out of bed, eating, drinking, mobilizing, and doing the basics that we all know are effective in ERS. As far as our protocol specifically, I think we've taken the advice from people that have implemented these protocols before. And the first thing you're going to do is try to find the low-hanging fruit, those easy things. So we developed binders based off of some of the medical literature that we have access to and contracted with Mizzou to help describe what the surgeries are and what the recovery will be. And then, we antifibrinolytics for cardiac surgery we implemented, which was an easy one, just to have basically a protocol to make sure everybody got them intra-op and got them at the correct time. Infection control was a big thing for us because we were having a significant amount, or what we considered a significant amount, of sternal wound infections, even though the STS data wasn't that far off from national average, but we felt it was a big opportunity for improvement. So we looked to see what we could do for that and implemented that. And we've seen success out of that protocol as well. Those are a couple of the ones I can think of off the top of my head.
Yeah. So, Monty and I talk a lot about kind of the big pieces of enhanced recovery, that you kind of have to have in everything: the pre-op, multimodal, goal-directed fluid therapy, or goal-directed hemodynamic management, really. And then living the dream afterwards, making your patients are, drinking, eating, and moving after surgery. How do you kind of address those last two, living the dream and the goal-directed hemodynamic portion? Because I know in the heart space, that does look a little bit different for these patients.
For sure. Yeah. And I will say one of the biggest proponents of our Tiger protocols at Mizzou is one of our associate medical directors, who is also a urologist. And so when they implemented the protocol in urology, the biggest thing that he even talks about today is my patients are no longer receiving 6 liters of fluid for every case, even though it's an 8-hour cystectomy and there's a lot of fluid shifts that occur. And he saw those outcomes immediately. And that's kind of what he always goes when he sells it to other services. It's just a standardization of both pre-op, intra-op, and post-op care, but this is the benefit, intra-op. And so when it comes to cardiac surgery, goal-directed fluid therapy is a bit more challenging than the normal, just because of the fluid shifts, especially if you're going on pump for those. So what we've done is, starting about a year and 3 months ago, we implemented Acumen IQ, Edwards Advanced Hemodynamic Monitoring, in all of our cardiac surgery patients. We were typically, prior, we were SWAN for every cardiac surgery patient that came in. They received a arterial line, multi-access catheter with a SWAN, and we managed the patients based off that, both pre and post-operatively. We knew we didn't need it intra-op for some of our patients, but that's what the surgeons needed post-operatively, because we don't have an intensivist in-house overnight that is specifically watching cardiac surgery. We have one that's kind of watching all the ICUs, but typically the cardiac surgeons are managing their patients from home. So they needed some sort of objective data when they were called in the middle of the night to help manage the patient. So all the patients were SWANs prior. And once we implemented Acumen IQ, we were able to transducer. It gives us special hemodynamic parameters based off the arterial line waveform. And we were able to remove or not put in the SWANs in the patients that didn't need it. And even the patients that did need it, which in my opinion are the patients that are at risk for right heart failure or pulmonary hypertension patients, we were still able to get the SWAN out earlier post-operatively as well, because we still had all the data from the Acumen IQ. So the Acumen gives us data such as cardiac output, cardiac index, new parameters like DPET, which is a measure of contractility, which is a very dynamic environment in cardiac surgery. And we are able to help manage our patients better intra-op and post-operatively with that. EA-Dyne, which is, in my opinion, a measure of arterial tone, and also helps direct goal-directed fluid therapy. And then, HPI, just the number one, right, that is a hypertensive predictive index that tells us, anywhere from 5 to 15 minutes before a patient becomes hypotensive, with the whole goal of, not letting them be hypotensive for any period of time, or minimize the period of time that would increase the comorbidities that we know about are associated with hypotension.
And Brad, do you use the DPDT as well? I mean, we're using quite a lot of abbreviations here. We can dive back into a second, but in the cardiac world, the concept of the DPDT, it was familiar to us before. It was on the the modern iteration of it. The upstroke of the arterial line and the force of contractility was motherhood and apple pie, but now we have it there presented in a way that we can manage it post-operatively.
Yeah, so I do use that intraoperatively, and I use it in conjunction with the echo, because we still do TE on all of our patients. I say all of our patients. I think of yesterday's case, actually, we had a small 30-kilo patient that needed an ABR that we couldn't get an adult probe in, and the anesthesiologist was like, I'm not that worried about it from a hemodynamic standpoint because I have the acumen IQ to manage this patient. And we could have done epicardial just to check the valve. We eventually got a peak probe in, but we have that advantage now with the acumen that we don't necessarily rely on a TE intraop to manage these patients. So I think DPDT is one of the most useful things in cardiac surgery on the acumen IQ.
There was some centers where you never saw a swan. Let's go back 20 years ago, and that still lingers. Some places where you couldn't do a cardiac case without a swan. So that's and you couldn't see that much difference in the results, the outcomes. So you're thinking, well, this is interesting. Now, as you progress through the various different monitoring modalities, you think, well, actually, I'm getting so much from the swan, but I'm getting a lot about the right heart in reality. I'm really possibly getting left about the left heart. And then transesophageal echo became normal. So now you're looking at the heart and you start to understand that a bit more. When you use the arterial waveform technology, you're getting a lot more about the left heart and kind of the very complex patient. I take it all, because, and the less complex patient, sure, just work off the left heart information and step up from there if you need it. Is that a reasonable summary?
Yeah, I mean, I think that's why we're in the room and this isn't done by machines. We have to take all the information into account to manage the patient with that specific pathology or valvulopathy or cardiomyopathy. And that includes things like looking over the drape, right? We can see the RV on echo, but let's look over the drape and see what it looks like in real time there. And I completely agree. We have to know the limitations of the modalities that we use. For echo, it's still labor intensive currently. DPDT is easily measurable on echo, but there's not many anesthesiologists out there that are monitoring DPDT on a regular basis through a mitral regurgitant jet and then measuring it and making changes based off it. But now we have it every 20-second interval. We get changes to constantly monitor that patient. Same thing with cardiac input or cardiac output and cardiac index. We're not doing continuous BTIs on these patients to monitor that. We're looking visually, which we think we're pretty good at, but if we get that information out into an objective monitor, it's a lot easier to follow and trend. And I think a lot of these are trending numbers, and a lot of the value in it is the trend. We don't necessarily have to have absolute numbers to treat to know a patient needs an inotrope. Every patient has a different physiology to begin with, so we don't need to normalize it to a population. We need to correct it for that patient specifically.
One of the questions, Brad, that I had because I haven't actually been able to use this technology in the cardiac space at all. And, when it comes to HPI and the EA9, that side of things, to me, I remember, things change very rapidly in a cardiac case. So, the benefit, I think, of HPI, right, is that you have anticipation and some knowledge beforehand that hypotension is coming. But what is the value of that? Because I've talked to, providers that I've worked with for a really long time who've said they love having this technology in the OR with them, and they actually use it quite more than they thought that they would.
The benefit I see is one on our very sick patients with induction. So I've used this on a patient with an EF of 10%, severe aortic stenosis, or pseudo-aortic stenosis. And so we have that information before we induce the patient. And so I actually would just put it on the patient, watch the HPI number, and I almost treated the HPI when it actually got down and was stable in the 20s. Then the patient was stable enough for induction of anesthesia. I did a bunch of changes with the drips prior based off of the other information I had, which was DPDT, continuous SVR, those type of things. But that's numbers you can't get from a swan, even on continuous cardiac output, because those numbers are typically averaged over 4 to 8 minutes. So they're not rapid enough for the changes of inducing a patient through anesthesia. After induction, I've used DPDT to manage my inotropes, I think, and I don't want to stretch too far, but I kind of think as DPDT is going to be more related to a strain sort of thing, where it's more specific on echo versus index, which is more related to EF as far as a global, which, EF can be 50% on a patient that needs ionotropes because their contractility has gone down and their LV starts to dilate even more. So I think it's more specific, it's more dynamic to our contractility. EA dyne is an interesting one in cardiac surgery because, as you said, what it does is it tells us, is the patient going to respond to a fluid bolus? Is their pressure going to respond? Are they a pressure responder? But we kind of have to take the whole picture of cardiac surgery into play and know that I'm not going to necessarily optimize the fluid pre-bypass because there's going to be a lot of fluid changes going on bypass, coming off bypass, cell saver, those type of things. So my goal is at the end, when I drop the patient off, they're fluid optimized and we have good goal-directed fluid therapy then. One of the biggest advantages, I think, of it is the post-op ICU care. So currently we have the TE intra-op, right? And we have a physician anesthesiologist, a nurse anesthetist, an anesthesia resident, a cardiac surgeon, a first assist, a PA. Everyone's looking at the same patient, right? And then we take them to the ICU, give them to an ICU nurse who has variable experience as well. I don't know what it's like for you guys, but our CICU is turning over. These nurses are going to advanced practice schools of CRNA. They're going to travelers to potentially make more money. And so we have a lot of turnover. And that variability can affect patient care if you don't have a standardization. And so what we've been able to do is make a standard protocol based off these things, because before the ICU just had an information of potentially a cardiac index based off the Swan and a mixed venous and a blood pressure. I think most people that care for cardiac surgery patients, and hopefully most people that care for patients in general, know that we need to focus on flow and not just pressure, because we've kind of all we've had before is a blood pressure. So we want to make sure the blood pressure is good, but we may, squeeze them to no end and compromise our flow. And in cardiac surgery, it's more important, I think, even because these patients do have that cardiac pathology. So we developed a protocol that kind of treats towards flow and pressure, and hopefully to optimize it. It gives the ICU nurse, the intensivist, the cardiac surgeon more information postoperatively that they didn't have before to make, the good decisions for the patient, to have that good goal-directed fluid therapy to help prevent the comorbidities like AKI that can occur.
Brad, one of the questions that's arisen about using HPI, we should remind ourselves HPI is the hypotension predictive index. It's machine learning, and it's a number presented by the monitor that tells us about the likelihood of subsequent hypotension. Now, on-bypass cardiothoracic surgery is notoriously associated with a quite variable pro-inflammatory response. And by that, we mean the modern use of the word inflammatory, lots of cytokines pouring around, possibly vasoplegia, possibly some cytokine-induced myocardial dysfunction. Do you get the impression, because there's relatively little literature out there so far, that the number is still reliable in that situation?
Yeah, and this is all new, like you said, so I can't say definitively for sure it is.
But your Gestalt, we'll go with Gestalt for now.
Yeah, I think it is. When I describe it, because I work with anesthesia residents every day, I kind of, when they first come to the OR and I talk about it, this is just a number that kind of tells us the cardiovascular instability or the likelihood of cardiovascular instability. And it's not a number or even an outcome that an anesthesiologist or somebody looking at an arterial waveform can predict. Right. And that was the whole basis behind HPI, is that there was no other number or person that could predict this, but HPI can. I think HPI works post cardiopulmonary bypass. I will say, the first thing people say about cardiac surgery is, well, you have external factors, right? You have a heart surgeon that's, or assistant that's leaning on the RV. I mean, that's cardiac surgery. We can't expect a machine learning to predict when that's going to happen. But if you look at the overall time period this patient has an arterial line waveform in, it is a very small amount of time that you have those external factors present. And so I think if we use HPI, like I said, pre-induction, pre-bypass, post-bypass, and hopefully eventually in the ICU, we're going to prevent these comorbidities that occur with hypotension.
So if I can take you to a late case in the evening, and we're about 4 hours out, and possibly we were hoping to be moving towards extubation. I don't know how it works in your neck of the woods. And everything's kind of looking okay with this patient. It's non-bypass cabbage. It's, it should be a relatively straightforward day at the office. And the HPI has been grumbling along in the 20s, for argument's sake, and it's now steadily creeping up to be in the 50s, 60s before it alarms, but it's noticeable. So nurse at the bedside has noticed this. What do they do then? Because they kind of think, well, everything else looks great, but I don't like what that number's doing. What do I call Brad? Is it time to call Brad?
Phone a friend.
Yeah. Right. No,
or do you give a fluid bolus or whatever? What do you do?
Yeah, that's where you can go to the protocol. I think the protocol doesn't necessarily implement until a MAP is less than 65. And I think it'll take education and experience for people to first trust the number. People don't trust it at first. It's a machine. It's a random number generator. But once you work with it, you really do learn to trust it, and it's very accurate. And you kind of let people experience it at first. HPI is 70, your MAP is 72. Like, well, I don't need to do anything. Well, to me, that's the opportunity to adjust the drips, right? Because when you adjust a drip in the ICU, it's going to take a little bit of time before that drip actually hits the patient and those vasoactive meds work. I've been in ICUs in the past where they do have access to bolus medication. Our ICU doesn't. So to me, even in the OR, that's where I use it. HPI is climbing. Okay, I go to the secondary screen. What do I need to treat? Is it contractility? Is it fluid? Is it vasopressors for a decreased SVR? That's where all that information comes into play. Is it gives you the information on what to treat as the etiology of it, not just treating the pressure with, let's say, phenylephrine for anesthesia's sake.
Your treatment algorithm is the same as forever. It's Guytonian, it's preload, afterload, contractility. I'm just thinking about it possibly 10 minutes before it may or may not happen, but I'm now thinking about what I'm going to do if it does unfold. And I think what we're wondering is when we get to the stage where we head it off right at the pass. Are you there yet yourself? Are you heading it off at the pass as opposed to waiting?
Yeah. I mean, that's where, so as you talked about, I think that delta HPI is just as important. And I think once you look at delta HPI jumping from 20 to 50, you're going to look at those secondary parameters and something else is going to be trending down, whether that be DPDT, whether that be, SVV. In cardiac surgery, I think it's important to know that we can use delta stroke volume, right? So you may give a 250 bolus to see if the patient is fluid responsive. But what I do with HPI is before I would wait till they got less than 65, I would give a bolus to temporize it. If the bolus worked, I would increase that drip of whatever medication I use. Now HPI is climbing. HPI is alarming, whatever the situation is, look at the secondary parameters, see what's trending down, and then adjust that drip prior to even giving a bolus. And a lot of times I don't even need to give a bolus anymore because we never reach that point because we adjust it prior to it happening, just like you would hope you would care for your patient like that.
Very cool. Thank you.
Yeah, that is very cool. I love talking about how you actually use it in practice. Let's back out just a little bit and talk about, you touched on it a minute ago, kind of the implementation science and change management, because I know many of our listeners out there from, the healthcare background, of course, and we know change is tough. And, we talk about how do we get buy-in? How do we get people, enthusiastic about adopting, new technology, new medications, whatever it may be. How did you guys work that at your facility? Because I talked to a lot of people and they're like, we don't need this. We haven't used it. It's not the Swan. It's not, we have, I can watch the waveform and I know when they are fluid responsive or whatever. Like, how did you guys do that there?
Well, I think you got to find a champion, and then you have to have people that are a little open-minded, or at least show them their own personal data, which is, I think, the biggest key. You can talk about how prevalent hypotension is, but the first thing you're going to get from someone is, well, that doesn't happen in my OR. My patients are hypotensive. I have great providers and anesthesiologists and ICU nurses that work with me. So you kind of put it on in the background, let it just grab data for a little bit for a couple cases, open that data up and show them, your patient was hypotensive 30% of the time they were in the ICU. If you're trying to reduce some comorbidities, you may look at this. Then I think the next step is kind of doing some education about it and then allowing it to kind of work with whatever their standard was. So we ran it with our swans for a while. And then people eventually adapted to see how we get more information, quicker information, and it's more relevant in the OR. And at first we had resistance from some of our anesthesiologists, but we kind of also just used it as education, right? So we taught the residents about hypotension, the dangers of hypotension. And so I would teach them how I used it. They would do a case the next day with someone else, and they'd be like, hey, I think I'm going to do this. Is that okay? And then the other attending would learn from that, from just having, the passive information passed along that way. And then again, we take it to the ICU. We let the ICU nurses do a QI project to develop the protocol themselves. So we gave them a couple different options as far as what was out there, and said, the whole key is just to find a standard protocol, right? There's not one specific protocol out there that's better than the others, but if you have a standard, then you can implement that. You'll see improvements, I think, from that alone. And then also you'll see opportunities to where you may be able to improve that protocol. And we've done that as well. The nurses picked out their protocol, we implemented it. And then we saw that, when we bring a patient up out of the OR, we kind of know where that patient's personal numbers are, that individualized treatment. So we changed our SVR line from 800 to blank. And then we would, say this patient's SVR, he does a lot better when they're at 1,000. So let's keep that number there, because we'd see, even when we, let's say we just treated SVR of 1,000, then we saw the index or the cerebral oximetry jump 12, 20%. We knew that the patient was just more in the vasoplegic state. They didn't necessarily need an inotrope, but they needed that afterload pressure to keep the coronaries perfused. So we've modified that protocol, and we've tried to get buy-in with all the nurses. I will say it is challenging, because we talked about that turnover, right? So it takes ongoing education for sure. And I think that's kind of our next step, is we need to do some more education for the nurses that have just come in to join us or just joined the cardiac ICU, so that they know what they're dealing with. And it's not just a random number generator or just another alarm in the unit, which of course is a big concern.
Yeah, for sure. No, I love that. We're dealing with that too. I mean, one of our units is all travel nurses, and they turn over every 13 weeks, so it was really becoming a challenge, and we're trying to overcome, how do we create even just a class for travelers, as soon as they come in, just like we do for new grads or new employees, like we do a whole, hour long thing on whatever it is, post-op treatment or whatever, to start taking care of them. So those are great ideas. Well, in our last couple minutes here, Brad, you mentioned about using cerebral oximetry, and this is something that, we've talked a little bit about in this space of cardiac surgery, and, realizing how we fit all the different pieces of the puzzle together and all the information that we have. So talk to us just a little bit about how that fits into, the program there, and especially when you're dealing with the whole team at this point, bringing our perfusionist colleagues in, especially during bypass when we're looking at cerebral oximetry.
So at first, I wasn't a big proponent of cerebral oximetry. I saw it as something that we were measuring, but we couldn't do a whole lot about. So it was a lot of the treatment algorithms out there are, I don't know if this is the proper thing, but I kind of consider it a cardiology consult in some ways, that, avoid hypotension, avoid hypoxia, and that's all you're supposed to do. Right. So I appreciate that information. But there's more to it, and I found it in the cardiac patient population. So we unfortunately did have a patient. It didn't used to be standard of protocol for us to have cerebral oximetry on all of our bypass patients or all of our cardiac surgery patients. We would typically just do it for aortic and circ arrest cases. Then we unfortunately had an event where a patient had a stroke, and it was the RCA looked like it probably could have been identified by cerebral oximetry. So we implemented it again in it's standard protocol that all of our cardiac surgery patients get cerebral oximetry. Again, anecdotally, my gestalt of what I've learned about cerebral oximetry is that it is a measure of flow. And so I can tell if my treatment has a positive or negative effect on flow based off cerebral oximetry. I'm not saying this has been proven in the literature, and there's other things that go into play like cerebral autoregulation, and I understand all that, but we don't have a great monitor in the OR that'll give us prospective data on flow. You can look at lactic acids every 6 hours, but that doesn't help you take care of the patient right then. So what I found is that we looked at our data again, and we looked at a couple cases that were performed by me or another anesthesiologist, and we would see that our blood pressure was fine, MAPS 85, 90 the whole time. And then we would see our cerebral ox just starting to trend down the whole way. And so we kind of looked at that as an educational opportunity to be like, hey, is this the right drug choice? I know the maps were fine. If we look at the arterial waveform, it looks great. HPI number looks great, right? We're not hypotensive, but it looks like we compromise flow in this situation. So we would change it up the next case, and we would first maybe treat with norepinephrine because that's kind of our go-to for our facility at least. And then we would see what the cerebral oximetry would do. Blood pressure goes up, right? Cerebral oximetry starts to go down. Okay, well, maybe this patient needs more flow. So do we move to, a fluid or inotrope? And so we changed the treatment, and then we'd see our cerebral oximetry climb. And it's very sensitive in the OR. And I got to show residents this the other day when we had problems, closing the aorta. So we had to drop our pressures for a little bit on bypass. And I'm like, watch what happens here, on cerebral oximetry. And within 30 seconds, it's dropping. And so I'm like, that's how you know that it's an accurate number, is that it can tell that fast. And so now I feel like I have more information again to treat the number now. It's not just a number on there that, okay, is the patient hypoxic? Is the cannula in the correct position? Do I need to raise the CO2 a little bit? It actually allows me to treat more towards flow, which has been a huge advantage, I think.
That's super cool to be able to integrate that into and actually see and confirm, or really make you feel a lot more positive and belief of the number, again, that it's not a random number generator like a lot of people try and say. So well, that's fantastic. Well, Brad, thank you for all the work that you're doing in this space. It takes a lot to step out and utilize new technology and go out and talk about it. So I think it's great that you're doing this, and really look forward to hopefully seeing some of the things, if you can get some of that work published, the data, coming out, and hearing more about that. I mean, it'd be great to have protocols too, and sharing those. It's one thing that we don't get enough of is sharing of protocols. Everybody feels kind of like you have to reinvent the wheel sometimes. So,
yeah. And that's one thing that I harped on from the beginning when we were implementing, or developing ERAS. I'm like, we do not need to reinvent the wheel. We're not out there doing research to see what works, what doesn't work. It's already out there. It's already done. Let's talk to our friends, see what protocols they have in place. And, like you said, I think we need to, the next step in the ERAS society, hopefully, will be sharing more protocols, not necessarily endorsing them, but at least sharing them as options so that people have an easier time to implement those.
Yeah. And you don't have to feel like you have to go to a million T&T committee meetings and, all the different, groups of trying to tell people, like, it's out there. Everybody, a lot of people are using this. So. Yeah. All right. Well, Brad, thank you so much. Really appreciate you taking the time again to chat with us. Hopefully we can get together in the future and maybe see you at ASA or one of the upcoming meetings. That would be fantastic to see people in person.
Yeah. Let's cross our fingers. Hopefully soon. Yeah. Thank you for having me. This has been great.
Yeah, absolutely.
Good to see you, Brad.
Yeah. And so, Monty, we want to make sure that everyone knows, again, just to repeat, that we will be definitely virtual, of course, for the EBPOM Ireland and EBPOM Chicago meetings coming up September 21st through the 23rd. If you haven't gotten your ticket yet, you can go online at ebpom.org and check that out, buy your tickets. Our ebpom.live.org hub, the EBPOM hub. Monty, what can they find there if they go there?
So they've got they've got various different pieces of materials from our previous meetings. There's on-demand content there, which is now quite extensive. Now, if you sign up to any of our meetings, you continue to get access to the on-demand content for the year. So I hope we offer tremendous value for money. Please don't look at the prices, but we start from $25 if you're presenting an abstract, for example. And our tickets are completely free to low and middle income countries. We ask our partners, industry partners, to support us, but we also ask our colleagues who are in better resourced countries to pay just a little bit extra for their ticket. The most expensive one is $200 for the double meeting experience. But we then flick some of that over to support our colleagues in low and middle income countries. And we know they're tremendously grateful for that support. So please do come and join in. There's a whole wealth of different information available in the Education Hub. And of course, TopMedTalk's got about 1,000 podcasts, so they're completely free and open access.
Yes, lots of information out there. And be sure, if you are joining us for the EBPOM Ireland Chicago meeting, to check out the pre-record specific to that, so you're all ready to go whenever we go live on the 21st.
Exactly.
Right, Monty?
So you need to. That's the good thing about registering soon, is we'll start to put up those pre-records, and there's quite a lot of homework to do, which you're under no obligation to do. But if you do want to join in on the day, we have almost no didactic lectures. It's almost all Q&A. It's panel discussion, because the didactics are available beforehand to, listen to in the car, watch at home with a cup of coffee, however you choose to do it, but on the day it's Q&A.
Well, thanks for listening. We appreciate everyone who joins in, and be sure to share with your friends. You can find us on social media and tag us there if you like a particular podcast or a video that you've watched or a lecture that you've listened to. And have a wonderful day. Hopefully we will see you in the fall. Cheers, everyone.
Bye.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.